So again, this is through AAOS, American Academy of Orthopedic Surgeons, emergency care, emergency care and transportation of sick and injured. This is through my EMT program. This is chapter 16, which is cardiovascular emergencies. So cardiovascular disease has been a leading killer of Americans since 1900. It actually accounts for about 1 in 2.3 deaths when you encompass all of cardiovascular emergencies. So 1 in every 2.3 of us is going to succumb to some form of cardiovascular disease in our lifetime. You know, we look at that date, 1900. Why 1900? Why has it become the leading when it was not before that? Well, if you think about the Industrial Revolution, if you think about going from an agrarian society to an industrial society where we did less work for more, more production, where we began to put preservatives and triglycerides and things in foods, that tends to lead to larger amounts of cardiovascular disease, unfortunately. We can, and this says EMS, but we all can help reduce risks by encouraging a healthy lifestyle, early access to medical care, and recognizing and teaching others in our job as medical health professionals, teaching others to recognize the warning signs, because some signs can be very subtle. And we know that, women, we know that the elderly can have atypical presentations. More CPR training of lay people, American Heart Association, American Red Cross, Green Cross, Safety Council. They all would love to see 100% of the population know how to do at least compression-only CPR. The amount of lives that could be saved if everybody understood CPR and the AED and how to use it. You know, the difference between healthcare providers and everybody else is everybody else kind of runs away from the scene. We run toward it. If more people would run toward it, we'd have more survival. An increased use of developing technology in dispatch and response, recognition, and of course, new treatment modalities. Public access to defibrillation devices. When I was a kid, the only defibrillators were in hospitals or big, paramedic style ambulances. Now they have them in grocery stores, they have them in airports, they have them in, bus stations, and they're small, about $500. Some of them even cheaper. So with that, defibrillation being the definitive care for the vast majority of cardiac arrests, lives are being saved. Recognizing the need for advanced life support and the need for hospitalization and the use of cardiac specialty centers. The main cardiac specialty centers we talk about in this area is UMass and St. V's, where they can do angioplasty, where they can do stenting, where they can do bypasses if necessary. So we're going to get in a little bit about anatomy and physiology. The heart's job is to pump blood, oxygen-rich blood, red blood cells to the tissues. The Fick principle states we unload the red blood cells with oxygen. We deliver those red blood cells to the tissues, and we offload the red blood cells, the oxygen from the red blood cells, and unload the waste product of carbon dioxide for excretion. If anywhere along that way we step in and we interfere that, you are going to have hypoxia, hypoperfusion of tissues, and of course that shock. The heart is the heart is a pump, and like any pump, it takes from one side and pumps to the other. It is a 4-chambered 2-pump system. The right side of the heart is what we call the pulmonary circulation. It takes blood from the body and pumps it to the lungs. The left side of the heart takes blood from the lungs and pumps it to the body. It's the systemic circulation. And if you were to look at a cross section of the heart, you would notice, like in this slide, of course, this slide is not super anatomically correct, but the right side of the heart is more than 2 times thicker than the left side when we talk about muscle thickness and oxygenation. Why is that? Because the left side pumps blood to the body. The right side of the heart's kicking back, smoking a cigarette, drinking a margarita, because it's nice and easy. It's got an easy job. It takes blood from the body and it just pumps it to the lungs. The left side has to pump against just systemic vascular resistance. It has to pump against the diastolic blood pressure. It has to bring blood around. So it uses far more blood. It needs far more blood and uses far more energy. Now I'm going to use my highlighter right here, and I think everybody can see it. Actually, what I'd like to do is use my laser pointer. We're going to follow a drop of blood through the heart. very simple. Everybody knows this. It's a great review. Blood comes in from the inferior and superior vena cava. Superior vena cava is everything from basically the shoulders and up, the brain, blood returning from the upper extremities through the subclavian veins, and it returns to the right atria. Then the inferior vena cava brings it up through the body. It all comes to the right atria. Through gravity and atrial kick, the contraction of the atria, blood pumps through the tricuspid valve into the right ventricle. Now, the right ventricle, when it contracts, pumps blood up through the pulmonic valve into the pulmonary arteries, the only arteries of the body that carry deoxygenated blood. It's not oxygen. It's oxygen poor. It's not empty of oxygen. There's still some oxygen in the blood. That's why compression only CPR does work. The blood travels through the pulmonary circulation to the lungs, where it gets oxygenated. It releases its waste product of carbon dioxide for excretion. Blood comes back through the pulmonary veins, the only veins of the body that carry oxygenated blood, returning blood to the heart, so they're veins. From there, it comes to the left atria. Through gravity and atrial kick, the contraction of the atria, blood travels through the mitral, or what we call the bicuspid valve. We call it the bicuspid because it has two leaves. It looks like two leaves. They call them cusps, whereas the tricuspid is three. That's where we get the name mitral valve. Mitral valve looks like a bishop's mitre with the two leaves, and that's where we get the term mitral valve. If you've ever heard of an MVP, mitral valve regurgitation, mitral valve prolapse, a heart murmur, those are all the same. When the atria beats, it doesn't completely close when the ventricles go to contract and blood travels back up into the left atria. You get that regurgitation. From there, the blood travels down to the left ventricle, and then the left ventricle contracts and it pumps up through the aortic valve, through the ascending aortic arch, and then the descending aorta. And of course, the ascending goes to, your common carotids, which bifurcate at the carotid sinuses, to the internal and external carotid arteries, and the subclavian arteries, which go up to the upper extremity. The atria receives incoming blood, and the ventricles pump outgoing blood. One-way valves keep blood flowing in the proper direction. It says the aorta, the main artery, receives blood ejected from the left ventricle, and the aorta then pumps it out to the rest of the body. This is basically the same slide, which shows the movement of blood, both on the left side, the systemic, and on the left side, the pulmonary circulation. On the right side is the systemic circulation, which we covered already. Now, the heart itself is an electrical organ. The muscles of the heart are fired electrically. What happens is you have the sodium-potassium pump, where potassium is the #1 intercellular ion, and sodium is outside the cell. So the potassium inside, sodium outside, there's more sodium outside than potassium inside, you have a negative charge. They exchange through the sodium potassium pumps, and that's where you get the more positive charge, and that potential, they call it the action potential. It is polarized, it is ready to contract. So the heart's electrical system controls heart rate and coordinates the atria and ventricles, okay? And it's through that electrical conduction pathways that we get the coordinated contraction of the heart. There's a term called automaticity. Automaticity by Latin means automatic movement. And what it is the heart can actually self-stimulate. The heart is super important. From about the 18th day of life, it begins to beat at a steady rate and rhythm, barring injury, until you die. And so the heart needs to have that constant supply of blood and that constant pumping. So automaticity is a way that the heart protects itself. So if the heart has damage due to an MI or some kind of trauma, other parts of the body can take over and fire, which we'll talk about in a minute. So automaticity allows spontaneous contraction without stimulus from a nerve source, like I said. If the impulse comes from the SA node, other myocardial cells will contract. It'll travel down through into atrial and interventricular nodal pathways, which we'll talk about. If no pulse arrives, then the cell will create its own pulse. So basically, this is the electrical. It's a little more complicated than this, but this is the basic diagram of the electrical system. First of all, in the upper right quadrant of the right atria, you have the SA node, the sinoatrial node. It's the pacemaker of the heart. It sets the intrinsic rate at 60 to 100 beats per minute. We know that 60 to 100 is about the average adult heart rate, 60 to 100. Usually it's around 70 or so. From there, it travels through the interatrial nodal pathways. And these nodal pathways circle all the way through the atria and allow the atria to contract downward in a smooth, coordinated fashion so that the atria is pumped down into the ventricles. So it pumps down. From there, the signal travels to what they call the AV node and the AV juncture, which is right after the AV node. And those two coordinate and slow down that pulse for just a fraction of a second. What happens is the atria have to completely contract and the ventricles completely fill in order to pump blood properly. If both the atria and ventricles fired at the same time, you'd have poof, and the heart would pop, and that would be the end of it. So the AV node and the AV juncture does an important job by slowing that heart rate down for a fraction of a second. Then from there, it travels down through the bundle His to the right and left bundle branches. Now, I know you've all heard of the term bundle branch block, and that's exactly what it is. You might get a blockage in the right or the left bundle branch. And what it does is it slows down that signal. It can block it. You know, we talk about, when we talk about bundle branches and we call them heart blocks, you could talk about type 1, type 2, so we can, you know, those are all slowing down that conduction of the heart. It's slowing down that heart's rate. And then from there, it travels down through the what we call the Purkinje fibers. The Purkinje fibers, like the interatrial nodal pathways, the Purkinje fibers do that in the ventricle, and it brings the signal all the way down, and it causes the heart to beat up in a coordinated fashion. So the heart squeezes in an upward direction. The atria squeeze down, the ventricles squeeze up, so that the ventricles can push their blood out to their respective areas, be it the heart, or be it the lungs, or be it the body, okay? And of course, if you have damage or injury to the heart, let's say your upper right quadrant of your right atria, you have a right descending coronary artery blockage, or somewhere along that line of a blockage, you have damage to the SA node, the AV node can take over, but it's not going to have that intrinsic 60 to 100 beats per minute. The AV node's intrinsic rate and the AV juncture is about 40 to 60 beats per minute. It's slower. This is where we end up with some of our bradycardias that we see, and patients end up needing pacemakers to get the heart to pace at the correct rate. The autonomic nervous system controls involuntary activities. We have the somatic and the autonomic. Somatic is everything I can control, everything I can do. My autonomic, the automatic nervous system. It's everything I can't control, and the heart is the part of the autonomic nervous system. Most of your muscle fibers, your internal organ muscle fibers, are part of your autonomic. Your external, your peripherals, your arms, your legs, you can move those. Those are part of your somatic. And then the autonomic nervous system is broken down further into the sympathetic and parasympathetic. We know the sympathetic is the fight or flight response. That's epinephrine and norepinephrine released from the adrenal glands, and that causes the alpha-1, which is vasoconstriction in the extremities, and vasoconstriction in the extremity, vasoconstriction, in the intestines and in the skin, in the periphery. Alpha-2, which is vasodilation in the heart, the lungs, and the major muscle groups. Beta-1, one heart, it causes the heart to beat faster, beat harder, and be more electrically stimulated. We call it a positive chronotropic, inotropic, and dromotropic response. And then beta-2, lungs, beta-2 causes the bronchioles to dilate and decreases mucus production. Epinephrine and norepinephrine, part of that sympathetic nervous system, the fight or flight, does all of that. Gets the heart to beat harder and beat faster and be more electrically stimulated. The parasympathetic nervous system is run by a chemical called acetylcholine. Acetylcholine is the parasympathetic that slows everything down. It's the neurotransmitter that slows everything down. So the sympathetic, epinephrine, norepinephrine, they're very fast acting in the body. They go very quickly. Acetylcholine lasts for longer. So there's a chemical in the body called acetylcholinesterase, which has to remove that, or you'd have an overabundance of parasympathetic and a very slow heart rate, among other things. The myocardium must have a continuous supply of oxygen and nutrients to pump blood. The heart itself has to have its own blood supply. It needs that because, again, from the 18th day of life, it's beating at a steady rate and rhythm. It has to have its own blood supply, to the point where the heart is the first organ to actually be oxygenated. The coronary arteries, which come off of the aorta, come off before the aortic valve, which means that the heart is literally getting almost a continuous supply of this oxygen-rich blood, of which it needs. Increased oxygen demand by the myocardium is supplied by dilation or widening of those coronary arteries, which would be part of that alpha-2 response. Stroke volume is the volume of blood ejected with each contraction. What is our stroke volume? Well, we know that in the average adult, the average heart, when a chamber is fully engorged, full, ready to pump, it has approximately 140 milliliters of blood in it. So each of the ventricles, when they're ready to pump, 140. Each of the atria, when they're ready to pump, have 140. Our stroke volume is the amount that's pumped out when that chamber contracts, and it's about 50% of the volume. So when our heart beats, approximately 70 milliliters leaves those chambers. The heart is a pump, and like any pump, it must stay primed. If I have a pump in my basement that's pumping water and I turn the water off or I lift it out of the water, what happens? It stops pumping. The heart, the same thing. The heart will stop pumping. It'll go into atrial fibrillation if there's not enough fluid for it to pump. It's what you get with hypovolemic shock. So that stroke volume is about 50% of the total volume in a fully engorged chamber, which is about 70 milliliters. And we call that, we label that as ejection fraction. If you have 100% ejection fraction, 50% approximately of the volume that's in a fully engorged chamber is being pumped out. So we say ejection fraction of 100% is about 70 milliliters. That's good. Now let's think about it for somebody who, let's say, has cardiomyopathy or maybe severe degenerative disease or heart attack, and now they're only pumping out 20%. So if you do the math, 20% of 70 is 14. So every time their heart beats, only about 14 milliliters comes out of that chamber. So what are they going to present as? Obviously, shortness of breath, cool, pale, clammy skin. They're going to be weak. They're not going to be able to climb stairs and things like that. So these are things we can look at. And you'll see that in your documentation. You'll see patients, cardiac patients with ejection fractions of 20%, 25%, and you know how they present. So this particular slide, and I think I jumped ahead too. Sorry about that. Coronary arteries are blood vessels that supply blood to the heart muscle. And again, the heart has to have its own supply. So we have the right coronary arteries and the left coronary arteries, and each coronary artery supplies a particular portion of the heart. The left coronary artery has a much larger area and muscle mass to feed. So if you think about it, the right and the left, which side of the heart is going to be more likely to have an occlusion and produce an MI? The left side more often, because it has far more blood flow and it has far more muscle mass and more blood vessels in order to feed it, more likely to have an occlusion. So left heart, left coronary artery, descending artery disease, and maybe the circumflex, these arteries can be the ones that are going to give you more of an occlusion and more of an issue. So here you can see kind of an overview of the larger blood vessels here. Things like your right descending, your left descending coronary artery. You got your marginal arteries, your circumflex branch, and they branch off smaller and smaller and smaller as they go down to feed, the 100 billion cells that make up the heart. Arteries supply oxygen to different parts of the body. You got your right and left carotids, your subclavians, which feed the upper extremities, which run off to your brachial, which runs between the bicep and the tricep. When it reaches the antecubital fossa, it bifurcates and runs down the left and right side, the radial and the ulnar artery. When our descending aorta travels down, it becomes the abdominal aorta right about the point of the epigastric region and travels down to just about the level of the umbilicus, and it bifurcates and it becomes to the right and left iliac artery. When it travels through the spine, through the pelvis, it goes under the inguinal ligaments in the center of the pelvis, and it becomes the right and left femoral. Now the femoral arteries run down the leg and run into the knee joint, where they become what they call the popliteal artery. And then from there, it travels down and bifurcates just in the upper extremity, down the lower extremity, where it becomes the posterior tibial or the dorsalis pedis. The dorsalis pedis is on the top of the foot, posterior tibial is on the back of the foot, behind the medial malleolus. And the perineal artery is, of course, the artery that feeds in the perineal region. Arterioles and capillaries are smaller blood vessels. You think about your aorta that comes off. The first thing I want to talk about is the cardiovascular system. It is amazing. It is a completely enclosed system. It consists of a pump, pipe, and fluids. Just like in my house, I've got a furnace in my basement. That's my house's heart. I've got pipes that feed my furnace on the third floor. Those are my blood vessels. And the water that gets turned into steam is the blood that pumps. So a steam furnace system in my house is the same as the heart, a pump, pipe, and fluids. We call that the perfusion triangle. This vascular system that we have is a completely enclosed system. The average adult, if I took all your arteries, which are the main blood vessels, your arterioles, which are smaller intermediaries, and then the capillaries, which we'll explain each one. The artery is the main blood vessel that carries blood away from the heart. When they did dissections of the body, they found these blood vessels did not have anything in them, and so they named them arteries, means lacking. Then the arteries go down to arterioles, which are smaller. There's approximately 40 intermediaries when you go from the aorta all the way down to the capillaries, because you can't fit an inch diameter aorta into a microscopic capillary. It can't be done. It's like putting a garden hose into a drinking straw. So it's got to get smaller. At the point where the arterioles and capillaries meet, we call it the arterial capillary sphincter. It's a sphincter-like muscle that opens and closes based upon the demands of the body and the demands of the tissues. From there, the blood travels into the capillary. The word capillary is Latin for hair-like. You can fit 100 of them side by side on the head of a pin. There are billions of them in the body, and those where the actual gases exchanges happen. That's where the oxygen leaves the capillary and the carbon dioxide is brought back in for excretion. From the capillaries, blood travels through an arterial venule sphincter into the venules. Venules are smaller blood vessels that intermediary between the capillaries and veins. The word vein, when they did dissections, they found these blood vessels had blood in them. They called them veins with blood. And so the venules meet up at the vein and, of course, carry it back into the heart with the vena cava. So we understand about the heart, the pump. We've talked about the pipes, the blood vessels. Right? And now we're going to talk about blood itself. What is blood? Well, blood is a fluid and three formed elements. About 60 to 65% of your blood volume is plasma. Plasma is a straw-colored fluid that has 25% of the body's oxygen dissolved in it, 25% of the carbon dioxide. It's got nitrogen, the nitrogen in the body. It's got insulin. It's got glucagon. It's got all of the chemicals and all the vitamins and nutrients that the body needs. It's all dissolved in the plasma. Then you have the three formed elements. You have your red blood cells, your RBCs, your erythrocytes, your hemoglobin. The word hemoglobin is hemi, which is one iron molecule, and four globin molecules. Each globin molecule carries one molecule of oxygen. When all four globin molecules have a molecule of oxygen on them, they're considered fully saturated. If all of your blood is fully saturated, your SpO2 is 100%. That's your oxygen saturation. That's what you're measuring. From there, your red blood cells, we also have white blood cells. Those are your lymphocytes. Those are your, and of course, we all know that, dealing with COVID all this time, right? We understand about the infection fighting and the T cells and the B cells. And then you have the platelets. And they're called platelets because literally when you look under a microscope, they look like platelets with these plates with these little sticky edges, and platelets aggregate together and begin the clotting cascade. A signal called chemostaxis sends a signal to the liver, releasing clotting factors, but the platelets begin it. They catch to the edges of the wound, wherever it is, and they start aggregating, catching red blood cells, and begin the process. So that's what's being carried through the blood. Blood pressure is the force of circulating blood against the artery walls, right? Every time the heart beats and that 70 milliliters leaves or ejected from the left ventricle, it comes out and it passes through the heart. That's what you're feeling when you feel a pulse. Your systolic blood pressure is that maximum wave pressure as the heart squeezes and the blood pumps. And then the diastolic is the resting pressure, right? That's your systemic vascular resistance. And of course, you all understand the mean arterial pressure. Mean arterial pressure is the calculation of your pulse pressure, which is your systolic minus your diastolic, divided by 3 and add it back to your diastolic. And that's the pressure that's needed that you're looking for. The average person, 120/80, it's 93.3 or 93. And that's the number in parentheses next to the systolic on most of your monitors that you see. And the mean arterial pressure allows me to know that I'm perfusing my organs properly. Obviously, a pulse is felt every time blood passes through the artery during systole. Peripheral pulses are felt in the extremities. Central pulses are felt near the trunk. We know central pulses would be carotids and your femorals. For infants and small children, you can actually use the brachial pulse as a central pulse because children have a larger surface area to internal volume. These are just different places where we take the pulse. We talked about the dorsalis pedis and the posterior tibial, and that's those right there. There is a radial pulse. There's also an ulnar pulse. You have to dig a little bit deeper, but it's there as well. So cardiac output is the amount of blood that passes through the heart in a minute, right? Cardiac output is calculated as heart rate times stroke volume. Well, what is your stroke volume? Your ejection fraction. We said it's about 70 milliliters for the average adult. Heart rate, about 70 times per minute for the average adult. 70 times 70, 4,900 milliliters, or about 5 liters per minute is being injected from the heart every time it beats. So you think about it, it's billions of beats and millions of gallons in a lifetime that your heart's putting out. That's why it needs that constant supply of oxygenation. Perfusion is the constant flow of oxygenated blood to the tissues and the removal of waste products. If that doesn't happen, you have hypoperfusion of tissues. The other term for that, shock. This perfusion triangle in circulation and the Fick principle is required for good perfusion. If cells do not get good perfusion, they die. They lyse, they release their potassium and other intracellular contents. One cell kills 2, 2 kill 4, 4 kill 8. It's an exponential process. Enough cells die, you injure tissues. Enough tissues die, you injure organs. Enough organs are damaged, and you have death of the organism through SIRS and MODS. So we've done our A&P, and we understand this. Now let's go into some pathophysiology. Chest pain usually stems from ischemia, which is decreased blood flow to the cells. We know that dead men do not tell tales. Dead cells do not show pain. So the very fact that a patient has chest pain means that cells are dying. Cells are being damaged for the most part. Ischemic heart disease involves the decreased flow of blood to one or more portions of the heart. We are going to get into a little bit of ACS, acute coronary syndrome. This is a buzzword now. It's become a buzzword over the past few years. Blood flow, if not restored, the tissue dies. Enough heart tissue dies, and the heart cannot pump properly. So atherosclerosis is the buildup of calcium and cholesterol in the arteries. We have two terms that we really talk about. We talk about atherosclerosis and arteriosclerosis. Atherosclerosis is kind of the buildup of those plaques. It can be caused by alcohol, it can be caused by smoking, it can cause by high fatty diet. Some people just develop cholesterol naturally. We know that cholesterol is important because all of the 50 to 100 trillion cells of your body need cholesterol. That's the lipid layer that makes up each of those 50 to 100 trillion cells, those little manufacturers, those little companies within your body that make you up. So you need that cholesterol, but too much of it, and you can get a buildup of this cholesterol and plaques. We also talk about arteriosclerosis. Arteriosclerosis is a hardening of the artery. That's most commonly caused by hypertension, the beating of the artery because of this higher blood pressure that it's constantly doing, and it literally alters the cellular structure of the arteries, hardening them. So between hypertension and high sodium diet, the blood vessels become hard and rigid. So the combination of atherosclerosis and arteriosclerosis both come from the root word atheroma, which means blockage or occlusion. And this is what happens during a heart attack. I actually like this particular slide that you're looking at because it kind of shows in the bottom section here how that happens. Now, there are two ways, and I use this slide. We're going to get into this in a little bit, but I use this slide because I like to show explain how this happens using this slide. First
You
of all,
didn't have it last night either?
I did have it last
Oh, you
night.
did?
Yeah.
first of all, I always ask my students, when is the best time, if you want to see heart attacks, when is the best time of the day and the best day of the week to see it? Go to the hospital. And usually students are pretty good, but only a few of them get the actual time and day. The best time to see a heart attack is Monday mornings. Monday mornings is kind of the largest portion because usually people are sitting back and relaxing over the weekend, and then you got to get up in the morning, get the kids ready for school, the car won't start, got to bring the dog out, got to get dressed, I'm late for work. That's when the stress happens. Oh, my chest, oh. And that's kind of the way it happens. This slide I like to look at because it shows the two things that can happen that can produce an MI. It's very simple, actually. That the inside of an artery is called endothelial tissue, and the body recognizes that like it recognizes skin. If it gets a break, if it gets a cut, the body will rush clotting factors to it and platelets to fix it. And that's what happens. During hard stress, you're out shoveling or you're mowing the lawn or you're cleaning the yard or whatever it is, this stress causes a crack in that endothelial layer, in that narrowed artery. That crack gets platelets running to it and it clogs it up. And that's where you have a heart attack because everything distal to that becomes ischemic. It doesn't get blood flow. This is one of the reasons why one of the main treatments, especially in pre-hospital, is aspirin, simple aspirin, 2 to 4 baby aspirin, 162 to 324 milligrams, or 325 adult aspirin, milligram adult aspirin. What that does is reduces the clotting factors enough that you will not get that buildup of, that you will not get that clot to get any bigger. It won't break it up. It's not TPA, it's not fibrinogen, but what it does do is it does keep the clot from getting bigger. And that saves lives. Or another thing and that's called a thrombus. That's a thrombotic heart attack, a thrombus. You can also have a piece of that clot break off. Stress, boom, boom, my heart's beating hard, piece breaks off. It travels down further and gets lodged in a smaller blood vessel and occludes it. That's called an embolic heart attack. You might have heard the term embolic stroke. It's the same thing. It blocks it. So you can have a thrombus, you can have an embolus, you can have a thromboembolus, which is a clot that breaks free and travels down. Either way, the bottom line is the blood vessel is blocked. And so blood flow distal to that is occluded. So what happens is the cells, they want to keep working. So instead of burning sugar, instead of burning glucose, oxygen and glucose, they're burning glucose and fats. And they're producing things like lactic acid, and it's causing damage, and the cell eventually dies. And when it dies, it lyses open, and a dead cell can tell no tales. It can't beat anymore. And so the heart becomes weakened. So we talked about a thromboembolism is a clot floating through a blood vessel. And again, it lodges itself in a coronary artery further down, and we get what we call an MI, myocardial infarction. The very term means death. So myo means muscle, cardial means cardiac, so cardiac muscle, infarction means death. So death of cardiac muscle, that's a myocardial infarction. We put the A in front of it, means it's happening now. It's acute, it's happening now, acute myocardial infarction. Cardiac disease is the leading cause of death in the United States. Again, it's one of the big three. 1 in 2.3 Americans will die of some form of cardiovascular disease. A good portion of that would be coronary artery disease. We put it on our chart as CAD. Many of our patients, especially patients who might be diabetics or hypertension, or patients who, have other conditions, will have high cholesterol, will have that. There are controllable and uncontrollable risk factors. So, let's talk about it. Some of our controllable risk factors. How can we control? Well, we can control our blood pressure, right? We can take medications. We can, watch our fluid intakes and watch our salt intake and take our blood pressure medications as necessary and maintain that. We can watch our diet and our weight, especially, I don't know if you've heard recently, they talk about diabetes and they talk about the pear shape, right? That weight that we carry around our midsection. And I have a little bit myself. That can lead to not only increased sugar, increased, hyperglycemia and type 2 diabetes, it can also lead to coronary artery disease. So that's something we want to do. That's another control risk factors. Reducing alcohol. They say 1 to 2 drinks a day, especially red wine, is healthy. Anything beyond that, and the risks outweigh the benefits. Eating lower fat meals and not eating so much red meat, maybe not eating red meat every day, maybe eating it every other day, incorporating more fish, things are more vegetables, very important. We get plenty of exercise and rest, reduce that stress. Sleep is so very important, and it's something that's lost here in America. What are some of our uncontrollable risk factors? Well, first of all, as a male, I am 5 times more likely to die of a heart attack than a female. I'm 5 times more likely to have a heart attack than a female. Yet, women are 5 times more likely to die of a heart attack. Why is that? Well, we can touch on that. And the reason why is because women have atypical presentations. They don't always present with that chest pain. They, women are always, they've got the jobs and they take care of the house and they take care of their husbands and they do all this stuff. And that's, don't get me wrong, that's not a sexist statement. Women work harder than men. I will never argue that. And so a lot of times women will say, oh, it's a cold, or I'm tired, or I've got things I have to do, and they ignore it more often than men do. And that's one of the reasons we touch on, and that's why I like to teach this, because I want people to realize that women are more likely to die because they don't accept or don't see the warning signs. Your African Americans, Hispanics, Middle Easterns, they have higher rates of cholesterol in their body. So races have a tendency to have a higher risk of cardiovascular disease and coronary artery disease as well. So age, being a male, your race, that all has something to do with it as well. And those are not really controllable. So here we go. Acute coronary syndrome is caused by myocardial ischemia. And there are two main buzzwords that we talk about. We talk about angina pectoris and acute myocardial infarction. So I'm going to talk about angina first. Angina pectoris, Latin, translated from the Latin, literally means pain in the chest. It occurs when the heart's need for oxygen exceeds its supply. It's a crushing, a squeezing pain. Many times patients who are having angina won't know the difference. And you'll look at the patient, they'll have cool, pale, clammy skin, they'll be having chest pain, shortness of breath, and you'll be like, this is the big one. It doesn't always, it's not usually death of heart muscle, it's ischemia. What happens, it could be a constriction of blood vessels, a spasming of blood vessels in the heart. We call that Prinzmetal angina, but it could be other factors as well, or just natural occlusion due to, natural occurring, atherosclerosis. And so the demand exceeds the supply. and that's when you get angina pain. It should be taken as a serious warning sign because 40% of patients who have an MI, a significant MI, have had at least one bout of angina within the previous year. And maybe they didn't recognize it, or maybe they knew it, whatever the case may be. There are two forms. There's stable and unstable angina. Stable angina means I go outside, I'm working, I'm shoveling, I'm cleaning up, whatever the case may be, but increased stress, increased myocardial demand, and that causes chest pain. Unstable angina is a little bit different. Unstable angina, I'm sitting back watching the ball game, eating potato chips, and all of a sudden, oh, I got chest pain. Or I wake up in the morning and, oh, I got chest pain. Fewer responses stimulate that pain. Unstable angina is far more dangerous and more serious than stable angina. We're going to treat all angina patients like acute myocardial infarction because we don't know. You might even see on the monitor, if I put them on a 12 lead, you might even see ischemia. You probably would see some ischemia. And so you would treat it like an MI. The difference with angina versus a heart attack is angina will go away with rest, nitro, oxygen, whereas your MI might be relieved slightly, but the pain will not go away. It will not be relieved. It'll still be there. So an MI pain signals death of cells. Well, actually what it signals is the fact that you have cells that are hurting and there are cells that have already died. Again, once dead, they cannot be revived. They develop scar tissue, and then the heart can't beat as well, and you can develop cardiogenic shock from that. Clot-busting drugs, thrombolytics, TPA, tissue plasminogen activator. Sometimes we just, bolus them with heparin. What this does is this helps to break up the clot, and then patients can go to PTCA, percutaneous transluminal coronary angioplasty, where they go in through the femoral artery, or they maybe go up through the radial artery, and using radiology and radioactive dye, they can inject it and they can see where the clot is. They can go in, break up the clot, and put in a stent. And a stent is like wire mesh that holds the artery open. And the thing with an MI is 40 years ago, 45 years ago, before they did angioplasty, before they did stenting, MIs were a fatal thing. You either survived it or you died. They took you in. If they couldn't do open heart surgery, if they couldn't do, you had to see. Now you could have a massive left coronary artery blockage, and you go to the hospital, and if you can get in and get stented within an hour, within a couple of days, you can be on your way to rehab or even home. It's amazing what we can do today with the type of medical advances that we've done. So let's talk about signs and symptoms of an MI. Well, first of all, an MI pain differs from angina because it's not always caused by exertion. It lasts several minutes to 30 minutes to several hours, and it's not always relieved. It won't be relieved. It might be eased, but it won't be relieved. It's still going to be there. That patient's still going to feel that discomfort, right? So what are our signs? What are our physical presentation? Well, we know we have the classic ones. That chest pain, that elephant sitting in my chest, I can't breathe. The shortness of breath, the cool, pale, clammy skin. You're going to have the nausea and vomiting, which is very common because of the sympathetic response. Your body is dumping epinephrine and it's causing the halting of peristalsis. Epinephrine stops GI motility and it stops blood flow to the intestines. And that's where you get nausea and vomiting, because the body says whatever's in the intestines, it's got to get out. It's going to go out one way or the other. So that's why during a heart attack, you get that nausea and you get vomiting. You get the chest pain. You get the cool, pale, clammy skin. Sense of impending doom. If your patient tells you something's wrong, you listen to your patient. I know a lot of times you have patients who, they always, oh, I get this, I got that wrong. But when a patient tells you, especially chest pain, you always listen and identify it, because you never know. Pain is subjective. You have to go by what the patient says. And chest pain is something that needs to be identified early, because time is tissue. In the hospital, they do door to cath time, and they want door to cath within an hour. We want to get the patient to the hospital within an hour. So from onset of symptoms to catheterization, we don't want more than 2 hours. We want to reduce that time if we can. Some patients will have atypical presentations, especially your diabetes, high blood sugar in the body, hyperglycemia destroys nerve fibers. So you don't have that same pain receptor function that you did before diabetes. Not only that, but elderly. The elderly, as we get older, we lose about 1% of our body's processing every year from after age 30. So you take somebody who's in their 70s or 80s, and their nerves are only firing at 50 or 60% of what they did when they were 30. So you add that on to diabetes, and then maybe make that patient a female. That patient may not have any pain at all. That patient may have, cool, pale, clammy skin, may have a little shortness of breath, maybe have a little abdominal pain, maybe a little nausea, but no pain. And so that's why the patient says, it must be a flu. I must be having some kind of GI thing, or, I'm not sleeping right or whatever, because they don't have that typical chest pain. Women don't. Women handle internal or visceral pain better, and they don't feel the pain the same way men do. That's why generally in EMS, if we have a patient with cool, pale, clammy skin, shortness of breath, a patient with GI symptoms, abdominal pain, we put them on the monitor. And you think, well, GI, why? Maybe he's got, gastroenteritis. No. It could very well be cardiac. Mid-scapular pain, epigastric pain, pain in the jaw. I once went on a call for a patient who had tooth pain, and something didn't seem right with him. His skin was a little pale, and we just put him on the monitor, and he was having an MI. His pain was in his tooth. So patients can present. That's why you have to look for subtle presentations. Look for the minor things, the little things. And when a patient or family member says something's not right, you got to listen to them. 3 serious consequences of an MI. Well, first of all, sudden death. If you have a major blockage in one of the descending coronary arteries, LCAD or RCAD, you can actually cause the heart literally to stop. It doesn't stop. It fibrillates. It goes into ventricular fibrillation. It's like slamming the brakes on a truck, and the truck goes, same thing. The heart does the same thing. Ventricular fibrillation, sudden death. And they will respond to the AED. So it's very important that we remember CPR and AED. Cardiogenic shock. Cardiogenic shock starts as soon as the heart is damaged. Once the heart cannot beat anymore, cardiogenic shock starts. Congestive heart failure, which is fluid buildup in the lungs due to hydrostatic pressure, because the heart's not taking the blood from the lungs, the left side of the heart, not taking blood from lungs and pumping it to the body. And so it builds up in the lungs. That takes about 24 hours to begin. So usually if you have a patient that has a heart attack, don't be listening for, fluid in the lungs unless they have a history, because it's not going to start right away. It's going to take a little bit of time, but that can be a warning sign, because congestive heart failure means the heart is not functioning properly. Maybe it's cardiomyopathy. Maybe it's endocarditis or valvular problem. Who knows? Dysrhythmias, heart abnormalities. There are different types. Well, first of all, you can have and we're not going to do a 12 lead EKG class here. That's a whole different class. There's 140 different rhythms. I could spend a whole semester on it, and people do. But we're going to cover some of the major ones that we're going to see. First of all, we call a PVC right here, premature ventricular contraction. If you look at the heartbeat, it's just a ventricular heart. The ventricle beats without stimulation from the atria. It just fires on its own. It just squeezes in the middle. It just pops up. If you've ever had that sinking feeling in your chest, like your heart skipped a beat, that's a PVC. Now, PVCs are fairly normal. Athletic, healthy people who drink a lot of coffee, who smoke nicotine, it's a common thing. But PVCs on a regular basis in the presence of cardiac issues can be the sign of cardiac injury. Tachycardia, which is a rapid heart rate, but the signal is working from the SA node. The heart is working properly, it's just very fast, over 100 beats per minute. Bradycardia is the opposite. The heart is beating normally, but the heart is very slow, and that could be due to cardiac injury. And then you can have ventricular tachycardia. Ventricular tachycardia means the ventricles are firing due to odd stimulation from multiple points. And so they beat very fast. Ventricular tachycardia, we can actually shock that. We can shock ventricular fibrillation and ventricular tachycardia at a rate greater than 150 because the heart's not firing properly. Shocking it stops the heart and it starts up again, and hopefully it starts up properly. And most of the time it does. Defibrillation restores cardiac rhythm as long as it is instituted within 2 minutes. This is an important thing. CPR is at best 50% of normal circulation. It's a stopgap measure. So what you need to do is ensure you get the defibrillator on as soon as possible. The American Heart Association and research study has shown if you get the AED on within 2 minutes and shock the patient, they have the greatest chance of survival. For every minute that you withhold or do not apply the shock, patient's chance of recovery reduces by 20%. That's why they say more than 7 minutes of CPR without an AED, patients usually have poor prognosis, unless they're children, unless they're cold, hypothermic, those are different. So the term asystole, A in front of any word means, as you know, lacking. Asystole is the only arrhythmia. It means no heartbeat. Now, it doesn't mean the heart's not doing anything, but the heart's not beating or moving with any, we call that flatline, basically. Untrue to Hollywood, you cannot shock asystole. I know they show it in the movies all the time. You hear flatline, shock them, boom, and the heart comes back. That does not happen. Asystole is brought back by medications like epinephrine, atropine, or amiodarone, and CPR. Those are the only things that bring back. Asystole represents a long period of ischemia. You do not go from cardiac function to asystole like that. You can go into what we call cardiac arrest, but usually the heart goes into ventricular fibrillation or ventricular tachycardia without perfusing. Asystole means they've been down for a long period of time, and nearly all patients will die from that unless they're very young or hypothermic. Cardiogenic shock is often caused by a heart attack, but it can be caused by other things: pericarditis, myocarditis, endocarditis, trauma. The heart lacks enough force to pump blood through the circulatory system. It loses that ejection fraction. Maybe it runs at 20, 25%. And we know the only way to truly measure ejection fraction is with a TEE, a transesophageal echocardiogram, where they can actually measure the amount of blood flow with each heartbeat, and that's how they identify ejection fraction. Inadequate oxygen to body tissues causes organs to malfunction. Not only that, but it also causes a hydrostatic pressure in the lungs to cause fluid to leave the capillaries and force its way into the alveoli and into the interstitial tissues. And that's where you get pulmonary edema. And that's where you get the congestive heart failure, right? So it often occurs, it starts in about 24 hours, but it usually occurs a few days after a heart attack. So when you have a heart attack, one of the things, if you have a major heart attack, they want to check your ejection fraction, and then they might get you started on Lasix. They might limit your fluid intake. They might start you on positive inotropics, trying to get your heart to beat better. Increased heart rate and enlargement of the left heart no longer makes up for decreased heart function, and that's where the congestive heart failure develops. You can also develop dependent edema. Right-sided heart failure will lead to a lower blood pressure because the less blood into the heart, the less blood out. Remember the Starling's law of the heart. So what happens is the blood pressure drops. You also get ascites or free fluid in the abdomen. You get sacral edema, you get peripheral edema, pedal edema. Left-sided heart failure causes fluid to back up in the lungs. Left-sided leads to right-sided, right-sided leads to left-sided. Heart failure is heart failure. Right-sided heart failure we called right heart hypertrophy or cor pulmonale, but that will eventually lead to left heart failure and congestive heart failure if not treated. They lump hypertensive emergencies into this as well. It's systolic blood pressure greater than 180. We talk about a hypertensive crisis at a blood pressure greater than 200. I'll be honest with you. I've gone to patients who've had blood pressures 160, 170, 180, and it's where I live. I take medication for it. It's the best they can do. People live like that. Arteries are strong. The outer layer of an artery, if you look at an artery, it has three layers. The outer layer of the artery is called the tunica adventitia. It's tough, it's fibrous, it holds the artery together, but it can only withstand upwards of 300 millimeters of mercury of pressure. When you start getting around 200, you're really whacking that artery, and you're going to change the cellular structure of the artery. It can lead to aneurysms, it can lead to MIs, it can lead to strokes. So hypertensive emergencies, patients will develop that headache, you know, intracranial pressure. When you have hypertension, you have a lot of blood flow to the brain, and it causes a headache, bloodshot eyes, a reddened nose, ringing in the ears, nosebleeds. I mean, I was a combat medic. I ran a battalion aid station, and I had one of my medics come in one morning, and he just wasn't feeling right. His eyes were bloodshot. He said he had a bloody nose. His ears were ringing. I took his blood pressure. It was 160 over 120. We took him right to the hospital. He was having a hypertensive crisis at that point. What it can eventually do, it can lead to altered mental status and pulmonary edema because of the pulmonary hypertension causing that hydrostatic pressure and fluid leaving into the pulmonary the alveoli. If untreated, it can lead to a stroke or dissecting aortic aneurysm. Patients must be transported quickly and safely, but you have to identify it. Hypertension is bad. Aortic aneurysm is a weakening of the walls, and we can have an aortic aneurysm anywhere along the aorta. We can have it most of the time in the upper chest, in the thoracic region. We call it a TAA, a thoracic aortic aneurysm. Down below the xiphoid process, we call it a AAA, an abdominal aortic aneurysm. In the thoracic aortic aneurysm, the most common place is right at the arch, because the blood is hitting that arch as it goes around. And if you have hypertension and the heart beating hard, it alters the structure, and you get the three layers to the artery. The internal layer is the tunica intima, and that's the endothelial layer where the blood travels through. You have the middle layer, which is the tunica media. That's the muscular lumen that dilates and constricts. And then the outer layer, the tunica adventitia. Well, because of that hypertension, the blood, it splits. Blood travels through the tunica intima, through the tunica media, and gets caught or lodged in the tunica adventitia, which is tough and fibrous. And it expands and bubbles. That's literally what an aneurysm is. It's a bubble on an artery, and they can develop anywhere along your thoracic, the length of your thoracic aorta. And they can be, I've seen aneurysms 3, 4, 5, 6 centimeters in size. 2.5 centimeters is an inch. The 6 centimeter aneurysm is a little over 2 inches. So good size aneurysm. Right? Primary cause of this is uncontrolled hypertension. Signs and symptoms, very important to recognize and differentiate. An aortic aneurysm, the pain is going to come on 10 out of 10 right from the outset. Bam. Oh my God, what is this? You're going to feel a tearing pain mid-scapular or epigastric region. Patient's going to be cool, pale, and clammy, and you're going to have different pulse pressures. On the right, you take a blood pressure, it might be 130 over 90. On the left, you take it, it's 80 over 40. The pulse is weak right to left. You're like, what is going on? Those are telltale thoracic aortic aneurysms or abdominal aortic aneurysms. Patients lie down, especially small, thin patients, you'll see a pulsatile mass in the abdomen. That is the aneurysm actually pulsating with the heartbeat. These are life-threatening because the aorta is rupturing, right? And so it can be dissecting or rupturing. Dissecting means it's developing. If it ruptures, blood travels into the thoracic cavity. Very, very rapid. I have taken patients from Lambert Hospital in transfers. They were having a dissecting aortic aneurysm. They were talking to me when we left. And by the time we got to UMass, which is 28 miles away, lights and sirens, we were doing CPR on them. That's how rapidly a AAA you can bleed out, even more quickly than that. It can be minutes because of that rupturing. And this is just the dissect the aneurysm versus an MI. You can see the difference. The big thing is the pain. The pain is going to be maximum on onset, and it's not going to wax and wane. Oh my God, something's tearing inside of me. That is a dissecting aneurysm. Whereas pain that comes on, it waxes and wanes. If I sit down, I feel a little better. That's more of an MI. Okay. And of course, the difference in pulse pressures. Blood pressure should be only off about 5 points between right to left. Your dominant side has about 5 points higher blood pressure than your non-dominant side. It shouldn't be off by 40 points. If it is, there's a problem. That's why we always teach doing blood pressures on both arms whenever we're dealing with cardiac issues. Okay. So at this point, I'm going to stop it here because I believe it has been an hour already. And I do not want to go beyond, too far beyond the hour. So I'm going to stop it here. Let me see if I can escape from this. Stop sharing. Okay, good. Excellent. And I'm going to put the chat on. And now I'm going to open it up to questions. If anybody has any questions or anything, feel free to shoot them out. You're welcome to speak to me, or you can type them in the chat and we can, I'll be glad to address them. Sometimes the question you don't answer, you don't ask, is the question everybody else is thinking. So shoot.
Can't think of anything.
I mean, if you can't, that means I did a pretty good job covering the material. I hope anyway. I hope that everybody was able to get something out of this.
It's really good.
Oh, how do you treat a dissecting aneurysm? That's an excellent question. The way they treat an aneurysm is they bring the patient in and they put the patient into an induced copia. They induce coma. They put they anesthetize them. They use therapeutic hypothermia. They bring the patient's body temperature down to about 89 degrees because that slows down cellular metabolism. They put the patient on a bypass machine, and then they literally will put a stent in that area. They may replace it or they may put in a stent. Most of the time, they kind of stent it and seal it.
Yeah.
I got a couple of excellent presentations. Thank you very much. I hope this was a great review for everybody. And for those of you it wasn't a review, I hope you were able to get something out of it. That's good.